Good morning. Welcome. So as you get joined today, I know that everyone's audio and video are still connecting. Please go ahead, find the chat window, and when you get a moment, if you can put your name, your organization name, and your location, your state, that would be wonderful. We'd love to know who's on and welcome you all. Also, there should be a poll that pops up. If you can take a couple of seconds and answer the questions on that poll, that would be helpful. We are going to collect that information at the beginning and at the end. So if you can just complete that poll, then you should be able to close it out so that it isn't in the view of the screen. Already have people joining and saying who they are in the chat. So we have Jody from Illinois on. She's from Fairview Nursing Home. Amber Cooper, she's from Golden Age Care Center in Iowa. Welcome. Michelle Ambrosini, she's from Symphony in Illinois. Welcome. Again, if you are just joining today, go ahead and complete the poll that appears on your screen. And then also in chat, if you can go ahead and put your name, anyone else who's in the room with you, that would be great too, what organization you're from and where you're located. We cover 4 states, so it's always interesting to know where people are from. I am seeing more people coming in. So Mary from very snowy North Iowa. It's also snowing in Colorado right now. We have Marilyn from Oklahoma. So welcome, Oklahoma. We have Glennis. She is from Southern Colorado. So that's wonderful. Thank you. Tina from Frozen, Iowa. I'm sensing a theme, but we are also getting snow here in Colorado as well. So let's see, no snow in Illinois yet. So thanks, Lisa, for the weather update there. Jen from West Point, Iowa is on. Welcome. Marquita Little from McLeod, Oklahoma. Mickey also says no snow in Oklahoma yet. So we're in our 4 states, we're half snowy. Again, if you just joined, go ahead and complete that poll that pops up on your screen. Once you complete it, you should be able to close it out so that it's not in the view of the screen. Gina Anderson, she is actually a Telligent staff member, but she is in lovely sunny Florida. Lucky her. We have more people from Iowa joining. Welcome. We have Amy Riddle. She's from Whiting, Iowa. Allison from Elmcrest and Harlan. Welcome. Oh, Lori, she's on from rainy Central Illinois. So you guys might not have snow, but it sounds like some parts have some rain today. Wonderful. So glad everyone could join it. I know it's early, especially in Colorado. All right. Again, if you have a moment, complete the poll if you haven't already, and then go ahead and put your name and info into the chat. We'd love to see who's on today. Susan is in Illinois near the Wisconsin border and expecting ice and sleet. Ooh, that does not sound fun. Diana is on from Southeast Oklahoma. Welcome. Okay. Keep putting in your name, organization, and state into chat. We'd love to see who's on. So welcome to the High Risk Medication Echo Series. Today is session 3, and the topic is behavioral support of residents in a long-term care setting. I'm Kristen Ives, and I'll be facilitating this session. I also have my teammate, Mickey Raymond, who will be chatting with you. And our wonderful guest speaker is Dr. Carrie Levy. She'll be speaking in a few moments. As a quick reminder, if you attend all of the ECHO sessions in this series, you will receive a certificate of completion. Also, as part of an ECHO, we really encourage you to turn on your cameras, chat with us, and even unmute and join in on the discussion. Collaboration is a big part of the ECHO model. This is a Project ECHO disclaimer for you to reference. It indicates what data is collected during these ECHO sessions. And then before we get into the presentation, we just want to remind you of a few ways to connect with Telegen. You can add us to your trusted list of email contacts. You can contact us on social media, and also check us out on our website, which has a lot of great tools and resources. Okay, so we all listen to webinars, but as you listen today, we really challenge you to think about how you'll use what you learn to create even a small bit of change within your day-to-day work or organization. The objectives of this session are to highlight some common causes for behaviors and also describe some non-pharmacological behavioral interventions to support residents. So we all know that CMS is looking closely at antipsychotic medication use. They recently started auditing nursing homes on accuracy of assessment and coding. And I just pulled in a recent report from the Office of Inspector General and a Journal of the American Medical Association study to highlight that potentially inappropriate antipsychotic medication use is being scrutinized. Knowing this, I think we could all use some new tools and ideas to support our long-term care residents. So that brings us to our wonderful guest speaker today, Dr. Carrie Levy. Dr. Levy is a professor of medicine at the University of Colorado, Denver, who trained in internal medicine and is board certified in geriatrics and hospice and palliative medicine. She received her undergraduate degree from Pepperdine University, her medical degree and PhD from the University of Colorado. She is currently division head of geriatric medicine, director of the Multidisciplinary Center on Aging at the University of Colorado, and section chief of palliative medicine at the Rocky Mountain Regional VA Medical Center. As a health services researcher, she focuses her research on improving long-term care for frail elders using innovative models of geriatric care. Dr. Levy, thank you, and I'll let you take it from here.
Thanks so much, Kristen. Can you hear me okay?
We can.
Great. Great. Okay. Well, thank you all so much for joining in this morning. I hope it's a valuable time for you and appreciate all the good interaction in the chat already, hoping for more, as this is a problem that we all encounter every day in our professional and often in our personal lives, as well as we care for loved ones and are asked to provide advice given our connection to healthcare. So we're going to talk about managing behavioral disturbances in dementia with a focus on non-pharmacologic approaches. Next slide. So I wanted to start by just grounding us in our time together. I know so often we've got distractions and other things vying for our attention. We just have a short time together. We just have about 20 minutes. So I'm hoping we can use that time wisely and allow you all to just be present. So I'll invite you to be present and close your eyes, do whatever is most helpful to you, and think about perhaps last time you felt agitated or anxious or uncomfortable in some way. And what surrounded that experience? Were you having pain? Were you being rushed? Were you being asked to do too much at once? Was there commotion, loud noise? And I'll just pause a moment. I see my doors open and people are coming into the office. So let me just close that while you're thinking. And then once you've identified something that has triggered you and agitation in you, please put that in the chat, or feel free, of course, to unmute yourself and share that with the group. Okay. If you've identified, oh, okay, thank you, Sarah, too much to do and not enough time to do it. Isn't that the truth? All of the above, loud noise, commotion, all of those things. Yep, indeed. We were at a restaurant this past weekend and the music was so loud and it was hard to hear who I was with, and it was chaos, exactly. Background noise, absolutely. So my hope is that we can all identify those things that are triggering for us in terms of agitation, and then really bring us to our task today, which is to be empathetic and hopefully get ourselves in the shoes of those who we're caring for, and see if we can identify what might be triggering the behaviors that we're observing. So I see anxiety caused by work pressures, too much stimulation, other priorities, and yes, this time and pressure is such a problematic. Hunger and hangry, excellent. Thank you. Thank you all so much. So if we can go to the next slide. What we're going to talk about today, I also really two things I'm hoping we can all walk away with today. Some practical tools about how to identify what might be causing the agitation and the behaviors that we're observing. And then the other thing is to try to separate the emotion that we can sometimes feel related to residents who are injuring us, injuring our staff, perhaps saying things that are harmful or that are perhaps not in the character of that individual. And sometimes this is towards family members, sometimes it's towards staff, and really direct that to instead the injury that's happening to the brain in dementia, and focus on that so that we can not allow the behaviors to be part of the injury to the brain and not necessarily the character of the person. So what I wanted to walk through is just this very simple model here. If we think of primary injury to the brain, that might be a concussion, it might be a hemorrhage, a stroke, it might be some type of edema, tumor, and certainly the neurofibrillary tangles that we see in Alzheimer's dementia can be that primary injury to brain. Then we also know that psychological trauma, emotional trauma, stress, PTSD, for example, can also accelerate this damage to tissue. I was taking care of someone last week who had lost 2 of her children. And during that time, she had started to develop some cognitive impairment, but of course, as you might expect, it accelerated after the loss of her children. So any type of psychological trauma and stress certainly places a burden on the neuronal tissue and causes additional injury and acceleration of some of this damage. So if we think of that individual who's acting in a way that's not characteristic for the person they've been all their lives, perhaps striking out, biting, hitting, or saying things that are harmful to staff or family, that if we can drill this down to neuroinflammation, excitotoxicity, oxidative stress, very subjective things that have happened to a brain to then result in what we're seeing on this particular day. And this damage can come in all types of areas or in all regions of the brain, but ultimately impairs the transmission of signals, and then cognition and emotions are disrupted. I feel like that's helpful to family who can sometimes feel like their loved one isn't, their parents aren't who they used to be, or their loved ones aren't who they used to be, and can say things that are emotionally distressing to them. So if you can communicate this to your families, your loved ones, that really it's the brain's not working as it once did. The signals aren't transmitting as they once did. And what we're seeing, that's what we're seeing today. It's not a reflection of the individual or perhaps of their emotions in that time. So the next slide, please. So that's really number one, is trying to separate what we're seeing from and look at it objectively as damage to that neuronal tissue, damage to those neurotransmitters. And then the second part is this assessment piece, which I think is really fun. And I'm hoping that this is a helpful tool for you. And I call it a day with Daisy. There's lots of different terms for this, but I think this is helpful. And what we're going to do is walk through a day with a patient and a resident and see how we can identify some of the things that might be triggering new behaviors. And so then the next bullet, really all we need are a couple of things, a sticky note. And then the next thing is some sort of a reminder, either on your watch or your phone. Hopefully it's a pleasant sound, so it's not alarming to you, but that triggers you to have a look at this individual who we're concerned about behaviors and see what's happening in their life. Can we put ourselves in their shoes and just walk around those for a moment and see what might be causing the behaviors that we're observing on this day. Next bullet. And so what we're going to do is a day in Daisy's shoes, and Kristen, you can just go ahead and put the rest of them up. We're going to look at what is the temporal onset and the course of these behaviors that we're observing, what might be associated, what circumstances, are there environmental factors, is it too hot, is it too cold, is it the activity, as you all pointed out, being rushed, being disoriented by the chaos, is it a particular care partner, someone who comes in the room and for whatever reason becomes a stressor to this individual. So that's the hope as we do some of this observation. I'm also very mindful that everyone on this call is extremely busy and can't do one more thing. So the idea here is that this is built into your day and a way to just understand and connect with those whom you're caring for in a very loving way. I think of this as a very loving way to understand what might be happening in someone's environment. So the next slide, please. So I'd like to tell you about Daisy. So she is a 72-year-old female. She is a retired nurse, and she was very active, bicycle rider, and always as pretty active, and remains so. She, however, has been confined to her room for the last 2 weeks, which is an unusual behavior for her. She seems agitated when she's approached in her room. She strikes out at staff when they attempt to walk her into the main areas of the facility. And when she is out in the main areas, she speaks about ghosts. She's very frightened and angry at everyone for stealing her possessions. And this is a new phenomenon for her. So knowing just that basic background, what's going through your mind? What's popping into your head as you think about what might have changed for her or what you want to investigate more? Okay, UTI, dehydration, absolutely. So we'll always look at what medically might have changed for this individual. We'll look at her vital signs, of course. We'll look at her behaviors to see if she seems to be uncomfortable. Has she had any changes in her patterns or urinary patterns, that type of thing. Excellent. So thank you, Kimberly, about med changes always. Whenever I'm speaking about geriatric principles, the first, second, third, and fourth choice are med, something wrong with the medications. And really with regard to her medications, she had some of these types of behaviors a month or so ago. And she was placed on Seroquel in the evening, and then she was also given an antipsychotic as needed during the day. She got very low blood pressure and very sedated once those medications were added. That was new a month or so ago. Nothing new has happened since then. Those medications were discontinued. Thank you. So for the pain comment, always a worry. And certainly she had a pretty significant event in that she was riding her bicycle in her neighborhood and was hit by a car. And this is one of the factors that was thought to accelerate some of the cognitive issues that she was having, because she did have a head injury during that bicycle accident and did suffer a broken collarbone as well. And so pain, great question. And we've given we've observed how she's interacting with others, how she's moving in her room, and she doesn't seem to be favoring any side or showing nonverbal signs of pain, grimacing, that type of thing. Thank you also, Candy, for the sleeping comment. Always a great question. She actually is sleeping quite well. She's sleeping through the night and seems to be doing all right there. A large area and too much stimulation, absolutely. So what we notice is that when she is passing through the hallways, she sort of escalates further as she gets further and further into the hallway. the shadow boxes that are next to the rooms are very disturbing to her. We're not sure why, but she looks at them and she makes an expression that looks frightened. And then also in the therapy room, anytime she comes close to the therapy room, she starts grasping her fists. And as we walk by the therapy room, she gets extremely agitated. So something about that as well. Thank you. Oh, these are such great comments. Okay, staffing changes. We haven't noted any changes. It's interesting. One of the larger CNAs, male CNAs, she seems to do better with, but she absolutely appears to be afraid. No roommate changes, but one big change in her activity is that she seems to pace and circle in one area of her room and doesn't want to come out to where the where she's got a chair and a few other things, her sitting table to get ready in the morning and that type of thing. She doesn't seem to want to be in that area of her room. And roommate change, she doesn't have a roommate. She has a single room. And did something happen with family and friend? Such great questions. Okay, so the other thing is her family has recently come in and tried to make her room a little bit more pleasant. They've added some photos, they've added a few things. And one of the behaviors we've noticed is that every time we come in, the drapes are pulled across her. She has a window in the back of her room and the drapes are pulled. And so staff, of course, wanting to orient her today and keep her oriented, have opened those each time they come in. And when they come back into the room, it is those drapes are closed. So we have our alarm set on our phone, and every few hours, every 20 minutes or so, ideally, but every hour certainly works as well. We'll just pass by her room and see what's happening. And these are the things we've noticed, that she seems to pace in her room. She's closing her drapes. She doesn't want to come out. And so if we could go to the next slide, we can talk more specifically about this specific method that some folks might find helpful. This was developed by Helen Kales, and she's done a lot of work in this area. This is an evidence-based approach to managing behavioral changes. It's called the DICE approach. I'm always a fan of acronyms, and this helps organize thoughts often. The first is to describe what's happening. So we've just done that with your awesome questions. And so we've described who, what, and where. It seems like something outside of her room is really troubling, and actually maybe some things inside of her room with the pacing and the circling around and closing the drapes. So we've gotten to describe a bit more about what's happening. And then the second stage in the DICE approach is to investigate. And you all brought a lot of these things up. Medication, is there been a change in medication? We know she had severe side effects related to the antipsychotics that were introduced a month or so ago. Her limitations functionally have not really changed. She's actually quite ambulatory and has been active all her life. Medical conditions, you all mentioned, we need to get to the bottom of anything like a UTI or some other change in her medical condition, which doesn't seem to be the case at this stage for her. There's no other psychiatric comorbidities that we're aware of. We do know that her cognitive impairment has accelerated, especially after the bike accident, and that's really what precipitated her admission to this care community. Her sleep hygiene is okay. Thank you for asking about that. And then fear seems to be a big part of this. Leaving the room, and then within the room, something doesn't seem to be very comfortable for her, and that's manifested in this pacing behavior that you're seeing. Caregiver, you all asked about that. For whatever reason, this one male caregiver, she seems to trust a little bit more, and he'll take her gently by the hand and be able to lead her out in the hall, and they can get a little ways, but still, again, the shadow boxes and that therapy room are really distressing to her. So then so we've gotten really awesome input in this short time. I want to look over and see a few other questions or a few other comments just to make sure we're taking those. Okay, nutritional change. She's not eating well because she's not really leaving the room. And so what's happened is meals have been delivered to her room, and then she's not real interested in them. And there's no socialization. So she has not eaten well in those last couple of weeks. The PTSD from the photos, great comment, or certain areas of the facility. Let's put a pin in that and come back to that. And then the acting out, does she want out of the facility, right? So often we don't think about somebody who's been on a bicycle and is used to being outside a lot and now is inside a lot. Is that causing her to be more agitated? And then changes with her vision, such great questions. We've not noted any changes, but of course with macular degeneration and some of the changes in eyesight, that can absolutely be a trigger for folks. Light sensitivity, let's put a pin in that also. So the next phase, so we've described, we've investigated, and even you can see in this short amount of time how much we have learned about Daisy and what might be going on. So the next stage, we've got information. Now let's create a care plan for her and collaborate with our CNAs, with our family members, with those who are caring for her, perhaps physical therapy, and put together some sort of a plan. And then of course, we'll need to evaluate that plan. I think what often happens is we create a plan and we're really excited about that and we hope it works. And then often don't go back to see what pieces of that plan worked well and what do we need to incorporate going forward. So let's go ahead and go to the next slide and talk a little bit about then putting this all together. So we learned a lot. You can tell how much we learned in even just a short period of time. I think this exercise is really fun. And if you can have a partner in the care community who's doing this with you, and the 2 or 3 of you go by and just observe what's happening. You've got your sticky notes, you're just writing down what you're observing, and invariably we'll learn things. We'll learn what comes right before the behaviors occur, and often can develop some really nice non-pharmacological plans for folks. Her daughter, I didn't mention this, but her daughter is an emergency room physician and was really concerned when the Seroquel was added and the olanzapine PRN. And then of course she had pretty severe side effects related to that with low blood pressure and then also just being quite sedated. And so she's very eager to be part of the solution and see what we can do to help. And that was actually one of the reasons they had come in and fluffed up the room a little bit and tried to improve things. So let's go ahead and go through a couple of the things we noticed in this process of describing and investigating. One was just as you had noted in the I think it was Apana had noted that certain areas of the facility might be a trigger, and then light sensitivity. Thank you, Kimberly, about the light sensitivity. So what we discovered is that you can see in this picture, this is one of the volunteers who is moving someone through the facility, and notice that she looked just terrified when she would glance at this window that was behind the therapy room, or was next to the therapy room. And you see shadows there. And if you didn't know what was happening there, or if your perception was slightly different, it could be quite frightening. And you may think that those are ghosts in that window. And that's exactly what seemed to be happening, where that discussion about ghosts was coming up. And then if you can put the next picture up, this is the therapy room. And as you may recall, she was hit by a car. And this car that was there for occupational therapy reasons was terrifying to her. And so this was likely part of the fear she was experiencing as she was walking past the therapy room. So these 2 areas seem to be a big trigger. And then, as I mentioned, the shadow boxes also had glass on the front of them, and that reflection, she would see that reflection and things moving in those reflections. And that was also really upsetting to her. So we learned a lot. It didn't take a tremendous amount of effort. It was actually really enjoyable for the staff to see what it was like to be in her shoes for a few hours. And so now my question is, what would you all like to do about these observations? Let me go back and look at the comments here. Yeah, getting her outside could be very helpful. Perhaps the additions that her daughter made to the room have been too much, and we need to remove some of those pictures that look unfamiliar to her, or that glass is causing a reflection. the curtains that she kept closing, we can certainly put a light curtain on, one that allows some light through but doesn't allow the reflections to be problematic. So we could put a thin sort of covering over the windows. Putting blinds over the shadow boxes is a suggestion. Thank you, Angel, for that. And the TV left on at night, right? That's always a problem. So thanks for mentioning that. So putting some decoration, stained glass over the window, right? Something that might be calming, covering the mirror. We actually removed the mirror because it was just too upsetting. And that's why she was avoiding that area of her room and pacing in the backside of her room. And then vision glare, cataracts, exactly. And she was willing to wear glasses, and we can get some non-glare glasses, which was helpful to her. And then the other intervention that a couple of staff members came up with was to actually allow her some control over her own shadow box, and to put some items in there that she found comforting, and develop a little bit of a different relationship with those shadow boxes. So she decorated her own. We didn't put the glass over the front of it so that she could sort of access it, and it wasn't such a frightening thing to her. And then she sort of noticed that other people had a similar display outside of their room, and she became curious about it as opposed to so frightened by the box itself. And then the car, right? What do you do with that car? There wasn't a lot we could do with the car. It was kind of a big deal, but staff were aware that that was a very upsetting area for her to go. And so we went the other way. It was a bit longer, but went the other way around the hall when she was going to the dining room. And then non-glare glass on the shadow boxes, sure. And you can put some mild film, basically, that won't glare on those shadow boxes. So thank you. That was so very helpful. And I think, Kristen, we're at time. So I'll go ahead and wrap up there. Do we have one more slide? Okay. So as far as messages, I hope you come away with the fun of all of this, right? It can be fun to develop some creative solutions and really get a sense of what is at the core of the agitation, and then coming up with some non-pharmacologic solutions, which you all did beautifully with. And then the other thing is to really think of this as a cellular change, as a change to the way neurons are working in the brain, and not a reflection of that individual's will towards you or towards family member, and help families understand that as well, because it can be upsetting when they feel like their loved one isn't the person that they used to be. And I'll stop there, and Kristen, let you take over.
Okay, wonderful. Thank you so much for the great discussion, the takeaways, all the participation in the chat. You guys were very busy, so thank you. Thank you again, Dr. Levy, for your tools, your insight. This was wonderful. So some next steps, we really encourage you to try the A Day with Daisy assessment, and then also meet as a multidisciplinary team and try the Describe, Investigate, Create, Evaluate, or the DICE approach. So we hope that you will try out these tools. And then also, we will be launching another poll here in a moment. So please go ahead and complete that when it appears on your screen. It'll just take 2 seconds. And then, let's see. Also, here is the listing of our upcoming ECHO sessions and topics. So once registered, you should have received a Zoom invite for all the sessions. And as I mentioned at the beginning of today's session, if you attend all 7 sessions, you will receive a certificate of completion. Please share this with other people in your network, people you know. We'd love to have them join the rest of our sessions, but we also have the previous sessions posted on our website. And then feel free at any time to give us a shout, to contact us, whether you have anything related to the topic today or any other topic. We're always here to support you and champion whatever you're working on. Reach out to us, let us know how we can help. And then if you haven't completed the poll yet, we will remain on for a couple more minutes so that you can complete that. And then just another big thank you to Dr. Levy for the wonderful presentation. Thank you so much. And then thank you guys all for taking time out of your very busy day to attend. I know it's early in the morning, but we really appreciate your time and your attention. So have a wonderful day. Thank you.